All the rage in stroke over the last 10 years has been about endovascular therapy in patients with large vessel occlusion. Early identification, the time window under which we can do these procedures, and of course, whether we should be giving lytics along with doing the procedure itself. There hasn't been as much talk about airway management, and I was surprised to find out that many of these patients are getting intubated prior to the procedure, especially those that are at high risk for airway decompensation, and that includes patients with a high NIHSS, those with altered mental status, and those with posterior strokes. In terms of that intubation itself, Etomidate, if you've got it, is the ideal agent as it shouldn't have much effect on the blood pressure, but you should still have norepinephrine on standby in case that patient demonstrates any hypotension after intubation. Once you get that ET tube in, contrary to what we do in most patients, you actually want to lay these patients flat. There are a couple of studies like the ZODIAC trial showing improved outcomes when the patient is laying flat prior to procedure, and this appears to simply be due to improved perfusion with that head down. So remember to consider intubating your patients with large vessel obstruction if they have any of those high-risk features for decompensation, or if you're transferring them to another institution, and after you intubate the patients, keep them laying flat to improve outcomes.